Okay, another area of care that we often use in substance use treatment or harm reduction is withdrawal management. And we'll do this with people who have initiated the desire to stop using. So we'll use detox as a starting place for treatment. They'll often do detox either on their own. It's not always recommended, but can be done on their own depending on the substance. And then they'll enter into residential treatment, or day program treatment. We also see people come into detox specific care, which is done. We have a couple spots where that's done in Edmonton. There's like the adult recovery unit and the complex medical detox at the ALEC, which are special settings just for detox. So it's sort of a short stay. People usually typically stay 3 to 5 days to complete their detox or withdrawal from the substance, and then move on to other forms of care. We'll also see people use withdrawal management when they're trying to do harm reduction as well. So they may not be deciding to quit substance use altogether, but they may need to give their body a break because of health reasons or just desire of ways that substances are working for them, that they'll decide they're going to take a break from, give their body a holiday, or get off one particular kind of substance. And so we'll see people use withdrawal management detox settings for that. Also, number one reason we also see this, I'd say, is in the hospital, where people are sort of on an enforced drug holiday sometimes, because they have been admitted for some kind of health crisis. And then because of the hospital generally being a place where you can't access substances as well, people end up going into withdrawal. And so that has to be managed there. Very, very common in a surgical unit post-op to be managing people's withdrawal on top of the other things that you're taking care of. And just to explain the different kinds of settings, because I kind of refer to them already, but when you think about where people using substance use disorders, people with substance use disorder will be seen and treated, you can see there's a full spectrum of care and lots of different places that they might be receiving care and where you as a nurse working in this area might be working. And also places where you might not know you're working in a substance use population, but you actually are, such as the hospital. We definitely have detox. This is all the kinds of places that people have detox. This is the kind of care that goes on there. So in a detox, we're managing the withdrawal. We're starting with engagement in treatment, which is a pretty fundamental part of withdrawal management. Care is helping people think about coming in, getting help, and staying to get help, because even though people have come there, often during withdrawal, people have a lot of shame and guilt about their situation. It's kind of like a given with any kind of addiction. People tend to feel even worse as they sober up, and their guards are down, and so that engagement is really a critical part of what we do there. And then treatment matching is where we decide what's next. So really thinking about where they're at in their stage of change, which we'll be talking about in lab, and what works and what they have access to and all those kinds of things. And then kind of case management referral to the next steps, which can include not just treatment options, but also things like housing options and relational supports that they might need, such as family counseling and things like that. So that's one phase. The other phase is treatment, which is usually group-based, pretty structured programming. You'll see that take place. Sorry, I realize I have these diagrams flipped kind of upside down. But anyway, the blue one is opposite of the orange. You already knew I had ADHD, so the fact I just noticed this should not shock anyone. Okay, anyway, so this usually takes place in residential day programs or day programs. So residential treatment places tend to be like 21 to 28 days, sometimes a little bit longer. Usually the private ones will be a little bit longer. This is group-based, structured programming. People get up in the morning, have breakfast. They're in groups and therapy sessions all day long. AA, NA, those kinds of 12-step kind of things going on. They're learning basic coping skills and communication strategies, and trauma work is being done. There's usually individual counseling and family counseling, or at least family meetings as part of the care, and then referrals to the next phase of care, which is the aftercare. Aftercare, which you can't see, does go on for about a lifetime, and that involves counseling, support groups, different kinds of housing programs. People might leave a treatment facility and go into what's called those halfway houses, which are considered sort of still a controlled setting in the sense of there's still a lot of surveillance and monitoring going on. So your ability to just sort of go home and have a 40 of alcohol on the kitchen counter, you're less likely to have that happen in a halfway house. So that's why people will sometimes do that as a transition to going back to independent living. But I would say the majority of people go back to independent living, perhaps with AA or NA support groups a couple times, 3 times a week or so. And that's the kind of thing, and they might have more in-depth individual psychological counseling at that point, depending on what they have access to and what kinds of things are going on. Alongside of all of this, there also are at the very top of this, primary care, corrections, and the general hospital are the areas where we see people coming in and out of, and we may initiate people into detox treatment and aftercare depending on where they're at. We might be monitoring how they're doing. Mental health care, obviously, we often will see people who have what we call concurrent disorders of both a mental health diagnosis as well as a substance use disorder. We also just might be the people that are following up with people after they've finished treatment, that they're now wanting to work on their anxiety disorder perhaps, or something like that. And then alongside of that is harm reduction services, which go along all of these things. So people, as I said, will use detox to decrease the harm on their bodies for certain kinds of drugs. In treatment, we need to be using harm reduction strategies to make sure people are not at risk for overdose or problems when they are discharged, knowing that this is chronic conditions. So relapse is likely, more than likely, going to happen. And as well, in aftercare, we want to make sure people have access to the information and different kinds of strategies for keeping themselves as safe as possible. Okay, so for this PowerPoint, I'm really going to focus in on how to do alcohol withdrawal management and opiate withdrawal management. So the very first thing we do when we're working with somebody who's entering into withdrawal care, or is somebody who we know could be at risk of going into withdrawal, so somebody who is going in for surgery who has a history of substance use disorder active, current, we need to be having this kind of conversation before it happens. And so really we need a really good history of substance use. I think, all of our patients should be screened for the kinds of substances they're using and how that might interact with the kinds of care we're providing wherever we work. And how do we ask that? Of course, asking about substances is obviously very stigmatized. And so some of the ways that often gets asked is, you don't use substances, do you? Or we say, do you use alcohol or any illegal drugs? I heard that question just last week for my 90-year-old dad, which isn't ridiculous that he might use other drugs, but the word illegal. And so when we use things like illegal and illicit, we tend to load the question. So asking in a really non-judgmental tone, something like, can you tell me about the kinds of substances you use perhaps every day or on even an occasional basis? Can you tell me more about that and how that works for you? What are the substances you like to use occasionally? And then I just always go with the an assumption that everybody's using something. It's just safer, and then I'll be surprised when they're not, and not in an offensive way, because there definitely are people with religious beliefs about substance use, but to sort of just assume, having worked with lots of people from those religious beliefs who were using substances, who were further stigmatized for using substances in those religions. For instance, I worked with a lot of Mormons who were really, really struggling to get help because they, of course, the loadedness of them being a Mormon who used substances was 10 times as bad as just being a person who uses substances. So I always assume people are using and then be surprised when they're not. I try to overestimate too when I ask the questions. So if you ask people, how many drinks do you drink a week? 2 to 3, then that's too low. So go high. When they tell you what the substance is, go high. So do you use that? You know, if someone tells me that they use cannabis occasionally, and I'll say, oh yeah, so like, do you use it a couple times a day? And people go, oh God, no, that's not occasional use, Holly. I only use it once a day. And you're like, oh, okay, that's actually daily use, but we'll go with occasional. And so I'm same with like alcohol. I tend to say, like, people say, oh, I just have few beers on the weekend. And I'll say, yeah, so like when you have a few beers with your friends, do you have like 6 to 10 or 10 to 20? And then they tell me that I'm exaggerating and they bring it down to 8. Always ask about all the substances that people could be using, because that could complicate their withdrawal. So we need to know that. Remember, prescription drugs are often part of the substance use. So even if people say, you know, you can have somebody who's coming in for withdrawal of alcohol, but you need to know, how do you use your benzos that you have prescribed for you? Have you been overusing any of your lorazepam or anything like that? Because that will complicate the withdrawal. Ask, really important question is, when was last use? Because that's going to help us understand the most likely onset time for the highest risk for the kinds of symptoms that we're trying to prevent. I want to know what people's previous withdrawal history experiences were. Most likely, if you're dealing with someone with substance use disorder, they've tried this more than once. They've probably tried it at home. They've maybe been in care a couple times. It's good to know how they felt in those treatments, just psychologically. How did they feel? What did they like about it? What didn't they? But also ask about the physical experiences they had in their previous withdrawals. So did you get really shaky? Have you ever had a seizure? That's really important to know. People who've had seizures are more likely to have them again. You want to know their other health problems, such as physical health concerns or any kind of mental health diagnoses they might have, and just so that we can help keep them stable. So if they have a cardiac history, diabetes, anything like that. So the signs and symptoms of withdrawal with alcohol are going to show up predominantly. People will become sweaty, they'll get a little bit shaky, have tremors early. Those tremors will get worse if they go untreated. They'll have increased pulse, usually because they're starting to get dehydrated. Their temperature will go up and their blood pressure will be up. They might be flushed. I don't know if I have that on here. They might be flushed, red. They might feel a little bit nausea with some vomiting. They'll be very, very anxious, slightly agitated too. They'll have a hard time sort of sitting down. Remember, we're taking a depressant off the brain. So what you see is this overdrive coming. That's what the symptoms really come from. We start to see things like tactile and auditory disturbances when people are entering into what we call delirium tremens with their alcohol withdrawal. Those are really bad late signs. Hopefully we're not seeing those, but we might if a person has come in sort of further along than we realized for their alcohol withdrawal. And so there may be day 2 of stopping drinking. We might start all of a sudden see these really quickly, or we'll see these in the hospital where people did not have a good history done, or else they didn't tell anybody how much they were actually using. And so they've gone into surgery, into the ICU for their recovery from perhaps a cardiac surgery or something. And then when they've been extubated, they're, 2 days later, they're in full-blown DTs. Often a headache, but disorientation, is also a late DT sign, delirium tremens sign. With opiates, we see a different kind of symptoms. Those symptoms tend to be just like you would expect, the opposite of what you expect to see when you give somebody an opiate. So instead of pinpoint pupils, we're going to see really dilated pupils, which is going to make people really sensitive to light. Photosensitivity is really common. They're going to have goosebumps. They're going to be shivery. They're going to have stomach cramps. There are lots and lots of diarrhea. Like, I don't know how to describe this for you, but basically it will be running out of them. Fluids start to just run out of them. They'll have this is if it's not treated, I should say, which can happen in some places. They'll have really, really runny noses, and their myalgia will be the stomach symptoms, and the myalgia will be the biggest complaints. People feel like their bones are being crushed, achy, very restless with a high pulse. So when we look at like what the diagnostic criteria is for alcohol withdrawal syndrome, basically somebody's had some type of heavy or prolonged alcohol use. And so heavy meaning that this can happen with binge drinking. You don't have to be somebody who drinks every day for 2 years. You will see this after people's trips to Vegas. And of course they have to be kind of not attributable to anything else medically. So that usually is coming through in the history. We use a CIWA scale to assess, and that's called the Clinical Indication of Withdrawal Assessment Scale. And there's an example there if you click on the link, which I put at the bottom of the video. And basically, we do this in a variety, depending on where you work. Usually, my experience in working in acute detox, we would do it every 2 hours. Unless somebody was very high on their score, then we might do it every hour. And then maybe as time went on, after they were over the thick of it, we would do it every 4 hours. And the scoring just relates to the level of withdrawal. And it's basically looking for those symptoms that we just talked about on the other slide. When we look at the severity of alcohol withdrawal syndrome, we start to see why the last use matters, because often we don't realize that the biggest risk for delirium tremens is actually quite late. So if you look here on this little circle here, is where you're going to suddenly start seeing people losing, getting disoriented, having tactile hallucinations, maybe auditory hallucinations, acting very confused, and going into full seizures. And we see that coming in around 2 days after the last drink. So, I mean, there's definitely people who could get this earlier, but so most of the symptoms start at around 6. They start to peak 12 to 18 hours later. And then should start to come down, but we should always remember there's always this risk of DTs showing up late. Seizures are always a risk with alcohol withdrawal and benzo withdrawal. I'm not teaching you about benzo withdrawal, but technically it's pretty much the same thing as alcohol withdrawal. They usually starts in the early. Seizures can happen in the early phase of withdrawal due to lowered seizure threshold from alcohol. And this is pretty common. So people who use a lot of alcohol often will have seizures even while they're drinking because of this, especially if they have a sort of seizure propensity. That's not actually a real word. I don't know why. I think I just made that up. A propensity for seizures. But typically we'll see 90% of acute symptomatic seizures emerging within 48 hours after people stop drinking. for a long time. Like, so, sorry, people who are drinking for a long time, stop. They usually don't, they can just show up. So you can have a CWA score that's mild and people can still go into a seizure. So just keep that in mind. There's always a risk for seizures in those first few days of withdrawal. And so that should affect the nursing care plan for you to think about. If I have somebody with a history of alcohol use who's stopping, even if I'm managing that, there could be still have seizures. And so I should have them on seizure precautions. And only a third of the people who have withdrawal seizures will develop DTs. Those things are not necessarily aligned. So DTs, or delirium tremens, is a type of delirium that happens with alcohol withdrawal syndrome. Pretty much looks like delirium you'd see in any case where people are having changes in level of consciousness, increased confusion and perceptual disturbances. But this one, like delirium, is always an emergency. Never forget that. Always a medical emergency. Doesn't always get treated that way, but it is. This one can go very fast. So people can become agitated and a little bit confused. And you can imagine with somebody with substance use disorder, especially in a general hospital setting, who perhaps even has a mental health diagnosis, which isn't unusual, right? 60% of people with chronic mental illness will also have substance use disorder. So they're there and they start acting a bit weird. People start to just assume it's just the mental health diagnosis, and we're kind of trying to avoid them anyway. And so this is the kind of thing that can go undetected and then blow up fast. And people will become unconscious. Their autonomic system starts to get whacked out, and they go into full cardiovascular collapse. 37% mortality rate if not treated. And as I sort of said here, they can look like difficult patients. This video is really good. Take a look at it. And it shows a good example of a busy kind of post-op medical unit where one of the patients looks like the priority patient, the patient who, the nurse has 4 patients, and the patient who doesn't seem like a priority, who's becoming more and more agitated and difficult, is the one that's going into DTs. And you can see it sort of slowly progress over a period of 8 hours. And I just want to say, the thing with DTs and alcohol withdrawal management is I used to have a full-time job where pretty much 20 patients a day, 10 of them on my roster as a consult liaison nurse practitioner would be alcohol withdrawal management, DTs, undetected withdrawals. So I would be spending all my time running around med-surg, ICU, managing withdrawals that people didn't see coming. So this is a really, really common thing. 50% of hospital patients, right? So are there because of alcohol use disorder. So remember that. So anybody who has a history of alcohol who we know has stopped drinking for whatever reason, choice, they're in detox or they're coming in for surgery, we should be having all of these things in place. And I think you probably have. Some of you probably have seen this in med-surg. I know students have told me they've seen the CWA in use. So people should be on seizure precautions automatically. Don't wait for the seizure before you start those. Great NCLEX question, by the way. So if you know what seizure precautions are, it's basically, you can't always prevent seizures, but we can prevent the damage that comes from them. So people who are going to seize are more likely to get injured physically. So we want the bed low. We want pads on the side rails. We got to think of them as fall risks. We want to encourage fluids. Whether they can take them oral if they're not feeling too sick, they can take them orally. If not, we will start a line. Often in detox, depending on where you work, but people who are chronically using lots of alcohol often are very malnourished and unstable with their electrolytes anyway, just because of their body absorption. And so we often would just start them on what we call banana bag, which has thiamine in it, and fluids, just to get their cardiovascular system back up and kind of the basis of it working. The thiamine deficiency can cause increased nerve sensitivity, and so can increase chance of seizures, and also all sort of some of the neurological effects of alcohol use disorder. And so we use thiamine replacement. That can be done orally, but it also can be given IV. So just depending on where you work, that might be the case of why somebody's getting a yellow bag. We do the CEWA scale per orders and medicate with usually benzodiazepines, depending on the score. And so that's standing orders, which I had posted on that other slide, will have like instructions for the protocol of what to do with the CEWA scale. Typically, we're using things like longer acting benzodiazepines to slowly titrate the person off, keep their system calm, and slowly transition their brain and nervous system off of a depressant. And that's why we use things like Ativan, which is probably the shortest acting benzodiazepine, but some of the other ones like Valium, which are more longer acting. Remember that those changes in level of consciousness or disorientation are an emergency. It's paranoia. I don't care, the guy has schizophrenia on his chart. He starts acting paranoid. You start thinking, we got a problem. Because your goal is to get somebody through the 3 to 5 days that it's going to take for them to avoid seizures and DTs. And your goal is also to be really nice to people who feel awful and are highly stigmatized and under cared for. So that's what all of your nursing care is oriented around. With opiate withdrawal, we have similar processes, a little bit different orientation to care. So remember that opiate withdrawal probably won't kill you. Alcohol withdrawal will, if it goes untreated for some people. Opiate withdrawal is more likely going to be the worst pain people have ever been in, so they'll never do it again, i.e. they won't actually stop using their opiates. So our goal with opiates withdrawal is to really try and keep people as comfortable as possible and as asymptomatic as possible. They're going to have some symptoms, but so that they will stay and try get off the meds, the opiates. We use something called the COWS scale, very similar to the CEWA scale, and we medicate for symptoms management. Symptom management often involves Imodium for the diarrhea, Tylenol for the body aches, which you can imagine is never enough, especially for people who have had massive doses of opiates. So their natural endorphin system is quite low, and so their pain is going to be quite high. Things like warm blankets, things like that will also help, so don't forget about those. We use things like clonidine, which is kind of a weird, what is clonidine? I think it's an alpha-1 inhibitor. Don't quote me on that. Some kind of alpha inhibitor. Anyway, it's actually an anti-hypertensive medication that we never really use for hypertension, but we use it for relaxing people's muscles, I think is the best way to put it, because we use it in Tourette's and opiate withdrawal. We use fluids if they can keep it in. It'll keep running out of them, but if you can get that Imodium to stop their stomach from moving, we'll try and give them as much fluids as they can tolerate. They're probably not going to want to eat. We've started using buprenorphine, bup as we like to call it, and naloxone, which is something that we use in withdrawal, although that right now is becoming controversial in Alberta, because everything's controversial in Alberta. But it's a weak opiate agonist, so it means that it kind of binds with those opiate receptors to to make them feel better. So they're getting some blockage, so they're getting some relief from the symptoms, but it's very weak, and it's not like it doesn't kind of reinforce the total blockage that they were experiencing prior when they were, using their oxy or whatever they were using, Dilaudid. So, and then we can titrate down off of the bupe. Some people will stay on bupe and do really well. There's been some really good outcomes with opiate withdrawal with bupe now that shows that we really shouldn't probably be doing it without. For opiate users, obviously the risk of overdose after detox is higher because they're going to be more sensitive, and they're often going to think that they can go back to their usual amount if they do decide to relapse. So we really have to be careful. You'll see this all the time. I don't know if you've noticed in Hollywood, everyone who dies from an opiate withdrawal is usually just left rehab. And that's not unusual at all. And jail is another place. When people leave jail, they're more at risk because they're going to have access to their old supplies, and they need to know they need to use less. And so this is where your harm reduction needs to come in. Hopefully this is their last detox, but it might not be. And just in case, these are the things they need to pay attention to. It's not unusual for people to be really contemplative. They had this good idea. They were pretty sure they were ready. And then when they got into the thick of the withdrawal symptoms, they've now started to think that perhaps they were crazy and they can never do this. So you need to do a lot of coaching and reassurance, building trust with them. These are people that typically have not been very much engaged with by health professionals. So this is a new kind of relationship for some people. Some people have been in treatment before, so they're okay with it. Other people, they've just spent their whole life hiding their addiction, so talking openly with a health professional about it is weird, let alone trusting that the health professional will actually take care of you and not just judge you and try to police you is a different kind of relation, right? And we do have to think about and pay attention to the kind of underlying mental health issues that might emerge. Sometimes they're just in that acute phase of adjusting to a sober body and brain. Other times it's because, for sure, as we know, as we talked about with adverse childhood events and things like that, that there often is underlying mental health issues that have been leading to the propensity to use substances to manage, such as anxiety and trauma, very big.